Good evening. Welcome to the webinar and greetings from Zurich. My name is Richard Bodymead. I'm the Marketing Manager for Geistlich Biomaterials in the UK, and it's my pleasure to be here to act as your moderator for this evening's presentation. We're broadcasting to you this evening from the University of Zurich, and we're extremely fortunate to be joined by two of the world-leading clinicians who also happen to be faculty members here at the university, Professor Christoph Hämmerle and Professor Ronald Jung. And they will be providing what I'm sure will be an extremely entertaining presentation for you on the topic of GBR Revisited. I'd like to start by telling you a little bit more about our two speakers this evening, starting with Professor Christoph Hämmerle. He is the chairman of the Clinic of Fixed and Removable Prosthodontics and Dental Material Science, including the Division of Implant Dentistry here at the University of Zurich in Switzerland. His specific areas of research include hard and soft tissue regeneration, imaging techniques, digital dentistry, scientific aspects of reconstructed dental materials, and he is a specialist in both prosthodontics and periodontics. Professor Hämmerle is a board member of the Osteology Foundation, council member of the EAO, and president of the Dental Campus Association. Our second speaker is Professor Ronald Jung. He's a professor of implantology and the head of the Division of Oral Implantology, again at the Department of Fixed and Removable Prosthodontics here at the University of Zurich in Switzerland. In 2008, Professor Jung was promoted following the award of habilitation in the dental medicine from the University of Zurich. And in 2011, he was awarded his PhD at the Vrije University in Amsterdam. He has membership in numerous professional and scientific organizations, and is currently the president of the Swiss Society for Reconstructive Dentistry and is a board member of the European Association for Osseointegration. Before handing over to Professor Hämmerle, I'd just like to give you a little bit of background about tonight's webinar, which is actually the fifth in a series of webinars entitled the Geistlich Webinar World Tour. And that's actually part of the Geistlich Jubilee. And you may ask yourself, what is the Geistlich Jubilee? Well, 2016 actually marks 20 years since the launch of Geistlich BioGuide, 30 years since the launch of Geistlich BioOS, and it's also the year in which we've reached the milestone of 1,000 scientific publications which demonstrate the clinical efficacy of and success in practice of Geistlich biomaterials. But Geistlich are also considered leaders in regeneration, which means more than just looking back, it means looking forward. And part of our vision is to share the knowledge that we've built up over the years in the industry, and it's this idea of sharing knowledge which is really at the heart and has inspired this series of webinars. The webinar is of course live and interactive, and we would encourage you all to ask questions to the professors throughout the presentation. We will collate all of the questions and have a Q&A session at the end of the webinar. I will draw your attention to a dialog box in the top of your screen, and that is where you're able to submit your questions during the presentation. We will look to answer as many questions at the end of the presentation as is possible, but if we run out of time, we will email out the answers to any questions which we haven't been able to cover. So once again, thank you for joining us for this webinar this evening, and I will now hand over to our first speaker, Professor Christoph Hämmerle.
Good evening, dear colleagues. It's a great pleasure to be part of this webinar. It's entitled GBR Revisited. Welcome for tonight's webinar. We are in Zurich. We had a beautiful fall day today with changing colors. Now the sun has set, and it's a good time to start this webinar. GBR is our topic. Let's start with the first question. How important is GBR for our daily practice and for the safety of our patients? Let's look at the clinical situation as it may occur in everyday practice. Encounter a patient, there's need for an implant, do a treatment planning, discuss it with the patient, make a cost estimate. Afterwards, the patient may say, thank you for the good explanation, I would like to have the implant treatment, and agree to the cost estimation of 4,800 Swiss francs. Next time, we do the surgery, placing the implant, and unpredictably, we have a dehiscence defect at the facial aspect of the implant. We will think, now I told her that everything will cost 4,800, now I cannot charge for the additional GBR. A colleague may say, do you think GBR is necessary for the safety of the implant and the good prognosis? Well, let's look at the study recently published by Jung and co-workers. The aim of the study was to test whether small bone dehiscence defects, 5 millimeter or less, left to heal spontaneously result in the same clinical and radiological outcome as small dehiscence defects treated with GBR. So what did they do? They had 28 implants with small dehiscence defect. They were placed in 22 patients. So we have two groups. 10 patients with no GBR and 10 patients with GBR. And both groups, of course, exhibiting the same type of defects with 5 millimeters or less of exposed surface that normally needs to be covered with bone. A re-entry was carried out 6 months later, so another clinical assessment, and then there were follow-ups at 12 and 18 months. Let's look into the results. The differences at re-entry at 6 months compared to baseline. The group with no GBR lost about 0.2 millimeters of vertical bone height. And the group with GBR, thanks to the GBR, had gained 1.8 millimeters. If you look at the distribution of sites here in the no GBR group, we have about half of them that lost some bone, and we have a quarter each that had stable conditions or had a little bit of bone gain. When we compare this to the GBR group, it's quite interesting. There was no situation with stability, so there was either a loss in a quarter of the cases or there was gain in 3/4 of the cases, which tells us that GBR, when it works very well, and sometimes it doesn't work, and then we don't have a stable situation, but there's a tendency for a bit of bone loss. Now, if we go on and look again at the marginal bone level at 18 months, we see that the group that had no GBR loses another 0.4 millimeters, and the group with GBR remains stable. Interesting findings. When we look clinically, probing depth, over time, there is no significant difference between the groups, and the same holds true for the mucosal level. So looking at the site only clinically does not tell us that underneath we have different bone levels. So the conclusion, small bony dehiscence defects left for spontaneous healing lead to high implant survival rates in stable soft tissues. However, the sites without GBR showed more marginal bone loss between crown insertion and 18 months. Further studies and longer follow-ups are needed to confirm or refute these findings. Okay, so how did the implants look like when the GBR was not performed over a longer period of time? Do we have a disadvantage without GBR? The study we just looked at had an 18-year follow-up, but implants we hope will stay in the mouth for much longer. So let's have a look at the study by Schwartz, Son, and Becker. It's a 4-year study. The aim of the study was to investigate the impact of residual defect type following GBR in the dehiscence type defect on the long-term stability of peri-implant life. Material and methods, implant placement with GBR in 24 patients, and there was a re-entry at 4 months. And what did they find at this re-entry? There's a control group. There's 8 of these 24 patients. There was no residual defect, so GBR worked perfectly. Then there was a group of 8 patients with residual defects of 1 millimeter and another group with a residual defect of 2 millimeters. So we have one group where we have intact bone, and we have 2 groups where the GBR did not fully heal the defects, and we have some dehiscence defect. What did we see at the 4-year follow-up? I'm just going to read the text. You don't have to look at the table because the text explains the important findings. Significantly higher BOP values at sites with a residual defect at 4 months after GBR. There's a tendency for more mucosal recession. And the question is this also a risk for the development of peri-implant disease? So in the longer term, we do see these changes between groups with successful and non-successful GBR, or situations where the implant surface intended for bone integration is not fully covered. So Schwartz and co-workers concluded implants exhibiting residual defect height values more than 1 millimeter are at higher risk of developing peri-implant diseases, and positive residual defect height values may be associated with an increase in mucosal recession and may therefore compromise the overall aesthetic outcome for implant therapy. Now, I really want to see long-term data. He said, not 18 months, we want implants to stay longer in the mouth, not 4 years either, longer-term data. Another study by Jung and co-workers. The aim of the present prospective study was to clinically and radiographically evaluate the long-term outcome of implants placed simultaneously with guided bone regeneration using resorbable collagen and non-resorbable synthetic membranes after 12 to 14 years, which we really now consider long-term. Material and methods. We were able to include 58 patients with more than 200 implants in these follow-up examinations. They still represent 80% of the initially 72 patients that were treated. And we have a very long observation period of 12.5 years. Patients received implants treated either with GBR using the resorbable membrane, as you can see on these two images, or with non-resorbable EP2FE membranes, as you can see on the two images on the right side. And in addition, there was a third group with implants fully placed in pristine bone. Here are some clinical examples of good results. There's one in the control group, nice aesthetic result, good bone levels. There's one in the collagen group, same type, and one in the EP2FE group. There were at 12 years also some bad examples. So control group with recession, clinically, maybe not so much radiographically. Same here for a collagen group, and also some bone loss and an aesthetic compromise in the EP2FE group. But let's look at the values, pulling all the data together. Here's Kaplan-Meier survival analysis up to 12.5 years. The control group had a survival rate of 95%, the collagen group of 92%, and the EP2FE group of 93%. All in the same magnitude, all very good results at 12.5 years, and no differences between the three groups. So the authors concluded the survival rate of implants placed with GBR was not statistically significant compared to implants placed in pristine bone without GBR. Clinically and radiologically, there was no difference between resorbable collagen membranes or non-resorbable EP2FE membranes. These procedures can be considered as safe and predictable therapies for long-term performance of implants. So we now have our answer regarding the long-term performance of implants treated with GBR. Now, we've looked at interproximal bone clinical parameters and survival rates. But the GBR was done at the buccal aspect, and this we have not really assessed. So, can we predictably regenerate buccal bone? It's a fair question. A study by Benich and co-workers, done at the University of Zurich and at Harvard School of Dental Medicine in the United States. The aim was to assess the dimensions of buccal bone and soft tissue and immediately placed implants over a mean observation period of 7 years. Here's what the investigators did. 24 patients received immediate implants with GBR for residual buccal horizontal defect with depronised bovine bone and a collagen membrane. So please note that there's a buccal bony plate, and between the implant and this buccal bony plate is a grafting material placed, and then the membrane was placed over top. The analysis included cone beam CTs at 7 years post-implant placement and regeneration. They found that 70% of the sites on CBCT presented intact buccal bone, as you can see on this slide. 30% did not show buccal bone. There was an absence, a radiographic absence of buccal bone. When we look at the difference, the buccal bone level, and we look at the ones where they were able to discern the buccal bone and the ones where they did not find the buccal bone, and we measure this difference, on average it amounted to 8 millimeters. So it's very significant. The investigators also looked at the mucosal level. And you can see here with this red line indicating the mucosal level, which was recorded clinically and transferred, as you can see, to the CBCT with some radiopaque material. Implants with buccal bone and implants without buccal bone. This difference was only 1 millimeter. So in conclusion, despite GBR procedures to augment buccal infrabony defects at immediate implants, 30% of the sites showed an absence of radiographic buccal bone 7 years later. Sites with missing radiographic buccal bone exhibited clinically successful tip integration. This is a really important finding and conclusion. So you cannot detect it clinically. The absence of radiographic buccal bone was associated with a mucosal level located 1 millimeter more apical compared to sites without intact buccal bone. So only 1 millimeter. So you need different forms of clinical analysis, also radiographs to assess implants. We need to note, however, that the reliability of CBCT to assess buccal bone needs to be thoroughly investigated. Maybe the buccal bone is there, but it's just not visible on the X-ray. So, regenerated bone inside the buccal plate was what we saw with this clinical study. And 70% did show and 30% did not show. Now what would happen if we regenerate bone also inside this gap, but also all outside to increase the contour? Let's have a look at the literature. Some interesting studies. CBCT and clinical measurements of delayed implants with simultaneous GBR using 2 different membranes, PEG and collagen, revealed stable buccal hard and soft tissues in 10% of the cases after 5 years. Study by Jung and co-workers. A follow-up of 5 to 9 years of delayed implant placement and simultaneous GBR demonstrated stable pre-implant hard and soft tissues in 95% of the cases. Study by Bruce and co-workers. So if you look at the right slide, we can say 95 to 100% of these procedures are successful in comparison to the 70% where the grafting was done inside the alveolus only. We can look at a study of 15-year follow-up, looking at simultaneous implant placement with GBR or control implants without GBR. It was an inter-subject comparison. Just one graph to illustrate this 15-year follow-up. This is a buccal oral dimension of bone and thickness. And we see in light blue the control placed in pristine bone, and in dark blue the GBR, where we had buccal dehiscences that were augmented, and now they were assessed with a CBCT to look at the buccal bone dimensions. And we look at the numbers, and we find 1 millimeter from the shoulder of the implant, 2 millimeters from the shoulder of the implant, and 3 millimeters from the shoulder of the implant. And in neither of these heights do we find any significance between the 2 groups. So we can conclude implants placed with simultaneous GBR by using particulate DBM and or autogenous bone in combination with collagen membranes did not significantly differ from implants completely placed into pristine bone with respect to 15-year implant survival, interproximal bone levels, and dimension of buccal bone and mucosa. So we can state that we can regenerate the buccal bone with success. The next question is, how much volume can we augment at the buccal aspect? Let's look at a study where the dehiscence defects were treated. We have 2 typical images from this study. The grafting material placed and the membrane placed. Closure, suturing for primary healing. We have good volume, and after some time, we look at the site again and we'll say, There's a reduced contour. Maybe you should be able to augment more and have a more stable contour. In any case, this is an annoying situation. What can be improved to better maintain the buccal contour? Or in other words, how can the GBR materials be improved in order to have a better buccal bone volume stability? Well, improvements could be done regarding the membranes or using different forms and types of grafting materials. Let's have a look at possibilities regarding membranes first. How big is the difference between these two types of membranes? We see an EPTFE non-resorbable membrane on the left and a native collagen resorbable membrane on the right. A study by Nanny and co-workers. The aim was to evaluate and compare the amount and morphology of the buccal tissue volume using two different GBR techniques at dental implants. You see an image, how two different images are overlaid and the difference can be calculated. Let's look at the study in more detail. There were 27 patients, implant placement in single tooth gaps, anterior premolar region, bone augmentation simultaneous with implant placement, and then they were randomized into two groups. The resorbable group, resorbable membrane, and a non-resorbable membrane. Here's an example from the non-resorbable and the non-resorbable membranes. Typical titanium reinforced, EPTFE, and the collagen membrane. We'll just look at some of the parameters regarding material methods. There was a CBCT taken before implant placement and augmentation. There was one taken immediately after the procedure. There was another one taken 6 months later to assess the outcome. There were also clinical measurements from the implant shoulder to assess the width of the bone gain at these dehiscence defects. We have the two groups, collagen and the EPTFE membrane, and we have the mean horizontal thickness of the bone. At baseline, it measured 3.4 millimeters for collagen and 2.8 for EPTFE. The measurement was done again at 6 months, and for collagen, we still had 2 millimeters, and interestingly, for the EPTFE, the same amount as we had initially. There's a higher standard deviation, but it's the same amount. So with the collagen, there was a loss of 1.4 millimeters, and with the EPTFE, we have complete stability. Looking at the CBCTs at the same time points, the investigators found a loss of 0.72 millimeters for the collagen group and only a loss of 0.1 millimeter for the EPTFE group. So, the investigators concluded both treatment modalities were clinically and radiologically effective in regenerating bone on the buccal side of dental implants, but changes over time and differences between the groups were statistically significant. Now, Ronnie, here's a question to you. I know that most clinicians prefer to use the collagen membranes, although we have just seen that the EPTFE membrane shows some better results in this particular study. Now, how should we put this into practice and how can we further develop these procedures? Please, Ronnie.
Thank you very much, Christoph, for this question. A warm welcome also from my side. I'm happy to participate here in this webinar. I think we are at the point where we have seen what can we do on the level of the membrane in order to increase buccal volume stability. But as you said, Christoph, I think there are many people, including myself, which prefer to have actually a collagen membrane because it's so soft tissue tolerant in order to work with this type of membrane. So we need to ask ourselves, are there any options how we can improve the buccal volume stability on the level, not just on the membrane, but on the level of the graft material itself? And with this, we move on into GBR, and we consider this now GBR revisited. How can we further improve the graft material stability? We would like to move from a more two-dimensional way of thinking using articulated graft materials into an area where we have more stabilized graft materials in a more three-dimensional way. With this in mind, we have initiated 2 in vitro studies performed in pig jaws with Javi Miramar from Barcelona. And in this study, the aim was to evaluate whether or not 2 different xenogenic bone substitute materials, articulated west blocks, used for GBR of current adhesins, lead to different amount of material displacement during wound closure. So we particularly look just what happens to the graft material just after we have closed the wound. Here's the model. We can see here a pig jaw, and we had very standardized models, very standardized defects after we have placed the implants. And here you can see how these defects look like. Thereafter, the 3 different groups have been randomly allocated to these different sites. Group 1 received a xenogenic bone block, which was adjusted according to the defect dimension, and was covered with a collagen membrane. Group number 2 had particulated graft materials and covered with a collagen membrane, the BiGAP membrane. So this might be, most of you, the standard of choice in many clinical situations on a daily basis. And group number 3 was then using, again, the granulate, meaning the xenogenic granulate particles, again covered with the collagen membrane, but additionally stabilized by using 2 titanium pins. After we have placed the membrane on top of this graft material, we performed then the first cone beam CT in order to see how much we augmented just after we have covered it with a membrane. Thereafter, it is needed to close the flap. That means we need to release the periosteum and we need to close the flap. And we all know there is a lot of manipulation taking place at the level of the flap, and we wanted to know what happens then to the volume of the grafted site. So we did then a second CBCT after suturing and flap closure. When we look now at the data of the CBCT scans before suturing and after suturing, we were pretty surprised about how much change is taking place just by closing the flap. We take so much time in order to meticulously place the graft materials perfectly around the implants, then we close the flap, and it's like closing the eyes. But here we would like to show what happens. When we look at the xenogenic bone block and the collagen membrane, he lost after flap closure 18.1%. And when we look at the technique which mainly has been used, the xenogenic granules covered with the collagen membrane without any additional membrane fixation system, we can lose 43% of the original volume which has been achieved just after I have done the GBR procedure before I close the flap. And the group which we used, the xenogenic granules, covered with the collagen membrane, which was additionally stabilized with titanium pins, we could reduce the amount of graft displacement to 19.3%. But still a high number of volume changes just taking place within the first time just closing the flap before the patient has ever started to eat on it, having a temporary reconstruction on it, or starting to brush his teeth. In the second part, we have additionally assessed a technique which we call the L-shaped technique. What is going to be used is a xenogenic granules which were embedded in 10% collagen. This is the BIOS collagen itself. And the BIOS collagen is going to be cut into a form, as you can see it on the screen, in an L-shaped form. It's easier to cut it when it's wet in order to get it to this form. And this L, made of BIOS collagen, is going to be placed on top of the implant. So we can see the L is going to be placed on top of the cover screen. And a membrane which is stabilized is going to be covered, is going to cover now this L-shaped graft material. And we compare this technique with using the same group as we have seen just before, the xenogenic granules, additionally with a collagen membrane which was also stabilized with 2 titanium pins. When we look now at the result, we were very surprised by seeing, using the L technique, we could reduce the amount of volume loss just after flap closure to 2.4%. And when we look at the group where we have used the granules, it was a good proof of principle because it shows that we were very standardized because before it was 19%, and here we have 20%, which we lost after flap closure. So it was also for us good to recognize that the technique used here was pretty predictable. So the conclusion for that study was that the xenogenic graft materials in block form or stabilized in 10% collagen significantly reduced the amount of volume loss after flap closure and suturing compared to partly xenogenic graft materials, which was just covered with membrane without additional stability. In addition, we could recognize that stabilizing the collagen membrane significantly reduced the amount of volume loss after flap closure as well. So finally, we can say that both increasing the stability of the graft material or stabilizing the collagen membrane with pins has a benefit in terms of volume stability after flap closure and suturing. And with this in mind, we would like to discuss now what kind of clinical concept are we going to apply based on what Christoph Hämmerle just presented and based on what we have seen here just on the level of these in vitro studies. We have originally classified all our defects into 6 different defect classes. Today we're going to simplify it to 3 different defect classes. The first 3 are considered so-called self-containing defects. So they have supporting bone walls which help us to stabilize the membrane. Therefore, the preferred choice for these type of defects is a collagen membrane, is the BioGuide membrane. We have a long-lasting tradition here, we have a lot of good documentation, and it's very tolerant towards the soft tissue. And on the level of the graft material, we have either the option of using the particulated graft material or the L-shape. So whenever I consider a case as aesthetically demanding, I'm going to go for the L-shaped technique in order to improve the volume stability at the buccal aspect of the implant. Here I would like to share with you one of these cases. It's a case of a young gentleman which is going to lose his 2 central incisors. So this is considered to be really a challenging aesthetic case, losing these 2 central incisors in a young patient. After tooth extraction, 6 weeks later, the implant placement has been taken place. And we can see there where we had the fistula, we had a significant bone defect, and on the right side, we had a small dehiscence defect. After implant placement, it reveals clearly that we have on both sides a dehiscence defect more significantly to the left. However, when we look at the side from above, from the occlusal view, we can nicely see that the implants are within the bony envelope and we have good supporting walls. That means, for us, the therapy of choice is using a collagen membrane. So in this particular case, which is considered a class 2 defect, we're going to augment on top of the implant surface by using granules in order to cover the contour. And then on top, we're going to do this L technique, which is meant to be then more a kind of a contour augmentation, not just primarily a bone augmentation. And here you can see when it is wet, the bias collagen can be easily shaped according to the dimension you would like to have. So we have this L shape. That's how it looks like. When there are 2 implants, we're going to use 2 of this L, and I'm going to place this to the buccal aspect of the implant. And here you can nicely see these 2 L on top of the implant sites, mimicking a kind of the root prominence of our future tooth. And in between, the irregularities are going to be filled up with the remaining graft material in order to smoothen here the surface. And here's the view from the occlusal part. Here are some other examples that you get a little bit of taste how this is going to be used. Here we use the bias collagen in a way to support the pontic area in the front area. Here are 2 other examples in the anterior area how this L is going to be used. We can see we place it a little bit above the implant. It is not meant that this is going to become bone. It is meant to support the tissue and to support the soft tissue in order to provide the best possibility for volume stability. The membrane has been tacked and stabilized by using resorbable pins made of polylactide. And here, that's how it looks like after flap closure. After a buccal connection and soft tissue conditioning, we could see here a very nice result in terms of having sufficient buccal volume and 2 implants which have been restored with 2 all-ceramic crowns here, single crowns for tooth 1, and 2. In just a couple of weeks before, I was able to see this patient again 8 years after insertion of the reconstruction. This is how the picture have looked like 8 years down the road. We still has a very nice soft and hard tissue contour here, mimicking a very natural situation. When we move on now into areas where we have more challenging defects, moving to a class 3 defect. A class 3 defect is then a defect where we have a non-self-containing defect, meaning that we lost or partially lost all supporting bone walls around the implant. Here we definitely need to have a membrane which is able to defend the pressure coming from the soft tissue. So in these cases, we still prefer using a non-resorbable synthetic membrane with a titanium reinforcement. And again, combined either with granules or also with the bios collagen. Here a case which represents a class 3 defect, a center inside, the left one, which has a fracture, buccal fracture, with more than 12 millimeters of buccal depth. And after tooth extraction, we can see here the extraction socket with a complete loss of the buccal bone plate. So here we do need a membrane and a graft material which helps us to support the tissues and the graft material in order to benefit from a nice contour. You also can see the implant in place with a complete loss of the buccal bone. And then membrane placement with titanium pins stabilized. And a situation 6 months down the road, it's a pretty more invasive procedure because we do have to have a re-entry procedure. We can see here the amount of regenerative tissue there. An additional soft tissue graft has been performed and a flap has been closed. And also here, with more efforts, a more demanding procedure, we were able to get a very nice soft and hard tissue contour, mimicking the natural situation. And again, this has been also restored by a screw-retained all-ceramic reconstruction, as you can see it here to the right. After having these 4 different defects, which we consider either the non-self-containing or the self-containing defect, we move on into the area where it is not possible anymore to place an implant at the same time as you do the grafting procedure, meaning that we are going to get into the area of a staged approach, where first the primary bone augmentation procedure is needed. The one at type 4 is a defect where we only need to horizontally augment, and type 5 is one which needs to also have a vertical augmentation. In these particular cases, we use a collagen membrane, bigut membrane, because we do get stability from the graft side. Because in these situations, still the standard of choice is using a autogenous bone block covered with the bios in order to reduce the amount of resorption on top of the bone block. Here a clinical example of a young lady which has an old bridge, and she was very unhappy with this artificial soft tissue there. After removing this bridge, you can see how much the reduction of bone and soft tissue has taken place. And here it was obvious that there is no option to place implants simultaneously with the grafting procedure. So here we do need to do a primary bone augmentation procedure. This has been performed with autogenous bone blocks and additionally graft materials. And on top, there was a layer of bios in order to reduce the amount of resorption on top of that. This could have been nicely shown by Carlos Majorana. He could show that by placing the bios on top of the autogenous bone, we can reduce the amount of resorption to half of that without using the bios on top. And again, covering these sites with a collagen membrane. This is how it looks like after suturing from buccal and the occlusal view. And then 4 to 5 months down the road, 2 implants were able to be placed at the position of the center incisor and lateral incisor. This is how it looks like then after soft tissue conditioning and providing the patient with porous-infused metal reconstruction as a bridge from center incised to the lateral incised. This is where we have started, that's where we have ended. And then as a last case, when we really move on even to more challenging hard and soft tissue defect in a horizontal and in a vertical way, I would like to present you this young patient. She had a horse accident where she had multiple fractures of the upper and the lower jaw. Here you can see the huge defect taking place here on the right side of the maxilla of this patient. She additionally had an orbital floor fracture and a fracture of the mandible. And this was then a clinical situation after the fractures have been restored. And now we were challenged by this huge vertical and horizontal defect. And the most difficult part of this case was the fact that just one side looked perfect for a young patient, and the other side was just a huge defect. In addition, what was the case that the left center incisor had additional fracture line towards the meso side. So this tooth needed to be extracted. But the idea was to use this tooth in order to generate more bone in the area of the midline, because this is the most challenging part at the end, to get there sufficient amount of bone. And we additionally used then the first molar, to move this one more mesially. For that purposes, we did a treatment together with the orthodontist using a palatal implant, allowing us to move the center incisor over the midline. So there was a huge need from our side to commit the orthodontics in order to help us really to move this tooth over the midline. It was a very difficult procedure and was a huge effort to be made from patient side and from the dentist. And you can also see how the mold further moved to the mesial aspect. This is how it looks like after we have moved the center incisor to the right side of the jaw. We had a nice amount of bone in the area there, which enables us to place an implant at the perfect position. And later on here, we could also place then a temporary reconstruction. And the center incisor helped us to generate sufficient bone here in the midline where we had this huge defect. And at that time point, we needed to extract then the center incisor. Here you can see what reduction we were able to get regarding the dimension of the defect. This was the dimension of the defect at the beginning of the treatment, where we had really large distances in the area and also in the buccal area. By reducing this dimension, we could reduce the amount of bone defect here significantly, which facilitated then the further primary bone augmentation procedure, only limited to this area there. This has taken place together with the maxillofacial therapy department by having here a bone block which has been placed in this remaining area. And after a 4-month healing period, we were able to place then additionally 3 implants in this area. The implant most to the left was still placed. This was the first one, and the other one could subsequently be placed. And again, also here, we did then a contour augmentation by using the L-shaped technique in order to get more volume in this area. And then the suturing procedure. And this is how it looks like after the healing. And here I think we achieved a nice bone contour, but we do not have a nice soft tissue contour. So we need to do some improvements, because this is really annoying after having done so much effort to do these type of augmentation procedures. And the question is, how much volume do we gain with either hard or soft tissue grafting? There was one study by Dave Schneider within the office of Uli Grunder, where we looked at which type of technique brings us to what amount of volume gain. So we had a total of 16 patients which have been treated first with a GBR procedure with a simultaneous implant placed. Secondly, they received a connective tissue graft. Then a buccal connection has been performed, and then the crown has been placed and has been followed up for 1 year. And on each time point, we did a volume assessment using an optical scan. When we look at the results, and considering the final result is 100%, we can see that with the GBR procedure, we reached 57% of the overall result. And surprising for us was that the soft tissue grafting contributed to the overall result to 53%. After 1 year, we lost about 3%. So both hard and soft tissue grafting were effective in augmenting perimeter tissue. The GBR procedure contributed a little bit more to the overall result. So the conclusion for that study was that the soft tissue augmentations after implant placement may contribute up to 43% of the overall result, which is quite a significant amount. And therefore, we think that in cases where we have extended defect, it is most often indicated to perform soft tissue grafting after bone augmentation procedures. And this was exactly the case here, where we do need to do a post-operative soft tissue grafting. Here we performed a split flap in order to get access to this area. Then we harvest a combined connective tissue graft, including a thin layer of epithelium, in order to place it then into the recipient side. This is just after it has been placed, has been sutured. And this is how it looks like at the time of suture removal. And then after a buccal connection and soft tissue conditioning, that was the contour we were able to achieve. That's where we have started. So we really could improve significantly the condyle area. And a very important step was really soft tissue grafting. This was then the wax up drying of this patient. This is where we have started. And then later on, we were able to place this all-ceramic reconstruction. Here, the occlusal view. Again, how we have started. And then we see here the buccal view and here the buccal view in total. So we were able to achieve a nice result considering where we had started. We had to cheat a little bit in the area of the lecturing side by having artificial soft tissue there. But overall, we were able to restore this huge amount of vertical and horizontal defect. Here's the X-ray illustrating what has been performed. And here the happy patient at the very end, seeing him at the first when we started the treatment. So with this in mind, we come to the overall conclusion. Within this presentation, we had 4 areas to cover. Number 1 was the question is how important is GBR for the safety of dental implants? Mr. Hämmerle could show that with small implant sites left for spontaneous healing, and we did not perform a GBR procedure, they showed more marginal bone loss compared to sites with GBR. It seems to be that GBR has an impact for the safety of our dental implants, but we do need to have further long-term data. Number 2 is, what have we learned in the past from GBR procedure? We have learned that we have very successful procedures using collagen membranes and also non-resorbable synthetic membrane, revealing a high survival rate of 92 to 93% after follow-up periods between 12 to 14 years. In the third part, we were discussing about how we further can improve the GBR materials in order to have better volume stability. There we could see that increasing the stability of the graft material and stabilizing the collagen membrane has a significant benefit of volume stability. And in preclinical studies, the L-shaped technique was able to further stabilize the volume to the buccal aspect. But further RCTs are needed. They are currently ongoing in order to prove this concept in a clinical environment. And number 4, what should we use for the GBR procedure in clinical practice today? You could see that it's not just one technique. We need to look at the defect morphology because the defect of morphology defines the material we are going in order to regenerate this defect. That means not one size fits all. We need to always adjust our treatment according to the defect size. And with this, on behalf of Christoph Hämmerle and myself, I would like to thank you very much for your attention. And we will start now with our question. And we are happy to receive questions from your side. You can already see that we received some questions here. So we'll read this question and Christoph and I will share then who will answer this question. So there was one question whether GBR means bios and bioguide. Christoph, a very simple question. What does it mean, GBR, for you?
GBR means biomaterial and membrane. This is very important. It's not only the biomaterial, to support the area where we want to have regeneration, but it also asks for the membrane. So both are important. This is a frequently asked question. And if we look at the research, BioOS and BioGuide clearly have been very thoroughly researched. We use them as safe products, highly predictable, with a lot of documentation. It does not mean that something else will not render the same results, but when you choose materials, be careful to look for the necessary, important and sound scientific background.
One additional question was whether we have submerged these implants or did we let them heal in a transmucosal way when we did these studies. I can answer this question by myself. The studies which we have seen there, the long-term studies, they have been made in a way that the implant have been healed in a submerged way initially, and a buccal connection has then been performed in order to uncover the implants. But in today's environment, Christoph, how do you decide when you're going to go for a submerged or a transmucosal implant?
There is quite good documentation demonstrating that GBR also works when the implants are transmucosal. But it's a very good question you're asking, Ronnie. How do we decide when to have them submerged and when not to have them transmucosal? I think there's been more emerging data more recently to have them in a transmucosal position. So both are well documented. But the question remains in clinical practice, in this given situation, now what do I do? Do I cover up or do I have it heal in a transmucosal situation? I would make this dependent on the size of the defect. Having larger defects, let's say more than 4 or 5 millimeters, I would preferably submerge. Being in the aesthetic area, again, I would preferably submerge. When placing more than one implant, preferably submerge. But in a posterior area, small defects, aesthetically not so important, maybe premolar, molar area, it's clearly easier for the patient because there is no second surgical intervention. For buccal connection, you can do it in a transmucosal fashion.
There's one question now referring more to the larger defects. The question how we stabilize the bone blocks when we do it in a staged approach. I think this question refers then to the clinical concept. Here, whenever we're going to use a autogenous bone block, they're going to be stabilized with screws, which need to have a sufficient dimension. They should not be too thick because otherwise you're going to weaken the graft, but they should have sufficient length in order to properly stabilize. Usually 2 screws are sufficient in order to stabilize the block on the receiving side. Now one question is also coming whether growth factors influence or can further improve GBR. Christoph, I think we have a long tradition of doing research with growth factors. And how do you see the value today with these growth factors?
Well, Ron, you were one of the early ones to bring the growth factors into clinical practice, particularly in the Hiss's defects. And you had shown very good results, but also for the control group, using the BioOS alone, in comparison to the experimental group, using the bone morphogenetic proteins. Both were very successful, but the histological analysis showed we have a higher density of bone, so it's more mature bone. So the question then comes, in which clinical situation will this make a difference? And we would like to use the growth factors to expand the indications, and particularly not having to use the autogenic bone blocks anymore. And currently running some studies looking at this. Can you give us a short feedback on the results so far? It's preliminary, I think.
Yes, there is one study we were always looking forward to getting a study where we really have using a growth factor, bone morphogenetic protein, and as a comparative material than the autogenous bone block. And we were able now to run a very demanding multi-center study where we compared the autogenous bone block with BioOS combined with bone morphogenetic protein 2. And the preliminary results show so far that we were able for the first time to really show that using a biomaterial combined with the growth factor is as effective as the autogenous bone in regenerating the volume in a staged approach. But further studies are necessary in order to go in this direction. But I think when we're going to do improvement testing, I think then we should try to solve the problem of not being so invasive by harvesting the autogenous bone.
Absolutely.
On the level of small or medium-sized GBR or defect size, I think there the growth factor might not be necessary because we have excellent long-term data with the materials we traditional use way.
Bone blocks, avoiding bone blocks, it can do a lot of good for our patients. You're absolutely right.
Now, one question is also, what is the experience from outside, you, Christoph, or mine, regarding material which are based on synthetic polymers, such as polylactide in GBR procedures, or maybe also referring to synthetic graft materials. In which situation you're going to decide using now a bovine material, as we have seen it here, as a graft material, and a collagen membrane, or in which situation you say, no, here I would like to prefer to go for a synthetic graft material covered with a polylactide membrane.
Well, looking at the membranes, many years ago, there were some very good products on the market with PLA, polylactide, and they showed kind of contradictory results. So they have a little bit disappeared. Today we see new products with different modifications and formulations from this group of materials for membranes, and there may be some promise for the future that they could help us solve some of the problems we have with the current materials available. But I think it's still a long way to go. And I think if we're closer to this when it comes to synthetic grafting materials. Yes. What do you think?
I think it's at the moment, for me, the confidence level is on the level of having the material which we have long-lasting documentation. This is, for me, the preferred choices than going into the direction of having these bovine materials. But there are some patients which have some hesitance using these type of materials. There, I do think we have some graft material which have also shown some documentation which we can offer these patients a solution on a purely synthetic basis. I appreciate a lot. I think we got a lot of questions. We won't be able to address all of them, but I think I appreciate your active participation. I think it shows us that our lecture was stimulating enough in order to that you're interested in posing this question. However, we are limited in time, and I think we need to close the session, and our moderator will take over for that. From our side, from Chris and my side, I think we're very much appreciated. It's always kind of an adventure doing a webinar, not seeing you in person there and just sitting in front of your computer. But I think it's a very modern technique in order to provide knowledge to people in a very easy and comfortable way.
It's been a real pleasure to do this with you, Ron.
Yes,
Thank you.
Thank you very much.
Bye-bye.
Bye-bye.
Now we'll have the closing remarks.
Professors Hämmerle and Jung, thank you so much for that really fascinating, real detailed, evidence-based presentation, and for taking the time to answer so many of the questions that have come in from our delegates. And thank you very much for all of you who are watching tonight for making this a truly interactive session and posting so many of your questions. So thank you. We're coming to the end of the webinar now, but if you would like to know more about our products or therapeutic areas, or if you wish to get in touch with your distributor to place an order, you can visit us at geistlich-pharma.com. And I mentioned earlier the Geistlich Jubilee, and as part of the Geistlich Jubilee year, we are inviting clinicians to submit, to upload your cases to our Jubilee microsite, and I believe that we already have over 1,000 cases on our wall of fame. So you can visit us at geistlich-jubilee.com, and you can upload your best publication, clinical case, or statement regarding Geistlich biomaterials, and there are great prizes to be won. Well, we are at the end of this evening's webinar, and it is indeed the final webinar in the series of Geistlich Jubilee Webinar World Tour. But we will be back bigger and better in 2017, so keep an eye out for more information about upcoming events next year. It just remains for me to say once again thank you very much for our presenters and indeed hosts here at the University of Zurich, Professor Christoph Hämmerle and Professor Ronald Jung. My name is Richard Bodymead. Thank you once again for joining us, and have a good evening.